what exactly is foveal cone phototropism?
So basically it is the tilting of the foveal cones towards the ray of light. When you change the pupil location, you also have the tilting of the foveal cone towards the newly created pupil, and that they have documented actually calculating the Stiles-Crawford effect.
What do you think is the learning curve for pinhole pupilloplasties? How do they go about it?
So basically the surgeon should be very well versed with handling of the iris tissue. So that's the first requirement. You should know pupilloplasty procedure to be done. For us and everybody, we commonly use the single pass phototropism procedure that we described about 5-6 years back.
Hi, I have Dr. Priya Narang with us today to talk about a very interesting topic which very few of us know the details about. Welcome, Dr. Priya, to our podcast.
My pleasure. Thank you for having me here.
You're welcome. So let's talk about what exactly is foveal cone phototropism. There's a lot of hype around this and not many of us know what exactly it means. Could you explain about that?
Actually, it's totally a newer concept, the foveal cone phototropism. Now, this concept has been into existence since early 1930s, but it has not been focused much on. And actually taking into consideration all the advantages that come up with that, I would just like to put in that foveal cone phototropism is like, you can just split the name. The phototropism means bending towards light. And when the photoreceptors and the foveal cones do that, we call this as a foveal cone phototropism. Now, how does that come into play? It is basically, the Stiles-Crawford effect type 1 is like, when you have the rays of light entering inside the cornea into the eye, the central rays, they are focused the most and the peripheral rays are dimmed out. And that is what the Stiles-Crawford effect 1 is there. And when you measure the Stiles-Crawford effect, the peak point where it comes on is decided by the foveal cones. And that is what the directional sensitivity of the foveal cones, it actually decides the foveal cone phototropism concept. So basically it is the tilting of the foveal cones towards the ray of light. So that is what we call it as foveal cone phototropism.
And how is this concept helping us as ophthalmologists? I mean, like in which aspect do you think we would be using it?
We actually relate this concept to the change in the shape and size of the pupil. Now, this can be post-traumatic or it can be created artificially with the surgery. So it's basically the correlation of the pupil size and location with the tilting of the foveal cone that we are taking into consideration. So basically coming to the fact is that, patients with corneal opacities, patients with corneal scars and all, we try, if you have a central corneal scar and you have a central pupil, the rays of the light, they do not actually happen to go inside the eye and create full illumination for the patient. So in these cases, what we try to just shift the position of the pupil from the corneal opacity to the side. Now, here comes in the factor of foveal cone phototropism. As it has been measured by many of the surgeons across the globe previously, what they have actually documented is that when you change the pupil location, you also have the tilting of the foveal cone towards the newly created pupil, and that they have documented by actually calculating the Stiles-Crawford effect. So the Stiles-Crawford effect comes maximum in the center of the pupil. So that's how they calculate that, okay, now this is just because the foveal cone photoreceptors are probably getting inclined towards the new passage or the new entry of light going inside the eye. So that's where it kicks in.
To make it more easy for people to understand, what you have told me is anyone with a corneal opacity or a corneal scar, where we usually would do a corneal transplant in these cases. And knowing the dearth for corneal tissues availability, then the chances of rejection, vascularization in these grafts, if we had another option to avoid this, then I think that would be great. So I think that's where this plays an important role. So for a surgeon who is starting out to plan on doing these eccentric pupilloplasties, are there some tips which would you like?
Absolutely. The first thing that the surgeon should analyze is the surface of the cornea, because the aberrations of the corneal surface increase as we go from center to the periphery. Secondly, when you create a pupil in the periphery, things become much more trickier, things become much more difficult at that point of time. So a wavefront guided image of the cornea should be available. And what we do it is, we do a Zernick analysis of the surface of the cornea. And then what we do is we choose the site with the least aberrations correlating with the clinical image. Like you shouldn't have a clinical opacity on that part, but yes, you should be having less aberrations on the surface of the cornea. So that's the first thing. The second thing is trying to shift the pupil to the newly less aberrated location on the cornea so that you get good focus of light going inside the eye. Thirdly, is the size of the pupil. We call this as a pinhole pupilloplasty. So it's not only just shifting a pupil. Now you cannot have a 3 millimeter or a 4 millimeter pupil located eccentrically, because then you have lots of aberrations going inside the eye. So we need to even close down the pupil to about 1.5 millimeters in size from all the sides, and also to locate it beneath the least aberrated cornea. So that's the concept. The rest of the thing, the photoreceptors behind, they usually take about 1 week to realign themselves. So you keep on monitoring the vision of your patient. The patient will markedly improve over the next 1 week post-op period.
Another question which I wanted to ask, like, when do the patients start seeing the effect of the surgery? And you clearly mentioned it takes a week.
It takes a week
for them.
It takes a week. It's not that you don't see anything on the first day.
Okay.
The patients are going to be very happy on the first day. But clinically, what we say is the mark of visual acuity on the Snellens that we take up as 6.6 or a 6.9, that is a 20/20 vision or a 20/40 vision, you get it after 5 to 7 days. So that's the clinical time which usually the photoreceptors take to align themselves.
Another question which I have for you, Doc, is how do you determine the size of the pinhole? Is it going to be 1 or 1.5? Like pre-operatively, can you determine that size as well?
Yes, absolutely. What we do pre-operatively is that we have a pinhole device with various gauges on it, starting from 0.5 millimeter to 4 millimeter. It keeps on increasing gradually at every 0.5 millimeter. You just have to place it in front of the patient's eye and make the patient see through that. And whatever size the patient feels optimal vision is, that you choose that size of the pupil for the patient to be created intraoperatively.
We have the leverage of decreasing the size post-operatively if we feel the need for it, or increasing the size of it. So that's the beauty of the...
Yes, definitely. You can choose the size of the pinhole that you want to create. Now, if you have a confusion, it is always better to create a smaller pupil, because you can always enlarge that pupil and you don't have to take the patient back in the OR for just enlarging a bit of pupil. But if you already have a big pupil and if you want to make it small, then you have to again take up the patient in the OR. So the best thing is, when in doubt, create maybe a 1 millimeter pupil. Ask the patient if the patient complains of any dim illumination or something of that kind. Wait for 1 week. After 1 week, if the patient complains of dim illumination or something, maybe you can just take up the patient on a YAG laser and just increase a little bit size of the pupil, and then that solves the problem.
We have done a lot of these eccentric pinhole pupilloplasties at our center with Professor Amar, and they're showing very promising results, especially in corneal scars and traumatic patients. And what do you think is the learning curve for a beginner surgeon who wants to do this? Like, how do they go about it?
The learning curve, that's a very good question. It's a technical thing. The basic requirement for doing this is that you should know a pupilloplasty procedure to be done. For us and everybody, we commonly use the single pass phototropism procedure that we described about 5-6 years back. So that's because, you can use any procedure of your choice, but we try to use that because it's simple, fast. You don't have to take multiple throws. You just take a 1 pass and 4 throws and you are sorted. So basically, the surgeon should be very well versed with handling of the iris tissue. So that's the first requirement. You should know how to do a pupilloplasty procedure. So that's a basic requirement, because when you are trying to create a pinhole, you will have to make around 4 to 5 attempts at least to close down the pupil from all the sides. So that's one thing that the surgeon should be knowing.
So ideally, any cataract surgeon, anterior segment surgeon should master this technique, because I think it helps them in all other techniques as well. Not necessarily pinhole, but any traumatic iris where they can change it. Thank you so much, ma'am, for being here.
Thank you so much. It was an honor. Thank you so much.